Good evening all. Delivering a healthy baby is the pivotal dream of any mother and family, and the honest and responsibility of fulfilling this dream lies with us obstetricians and sonologists. In this context, the first trimester is the most delicate and sensitive period of pregnancy. So here, we bring to you a comprehensive peek into this window of opportunity. Learn about the first trimester screening from basics to advanced from our elite panel of speakers and faculty. So we have arranged this wonderfully informative CME with Metropolis. I call our President, Dr. Jamma Madam, to give her welcome address.
Good evening everyone. A warm welcome to esteemed faculties, teachers, seniors and my dear friends. Today we have well-known speakers Dr. Monisha Banerjee, Dr. Ajit Gandhi sir, Dr. Sumit Chamaria. They will share the latest trends and advancement in fetal ultrasound and screening. Delivering a healthy, normal baby is the dream of every mother and family. It's our responsibility to try our best to fulfill it. The first trimester is the most delicate and vulnerable period of pregnancy and we need to optimize this. Claude Joule says, do the difficult things while they are easy and do the great things while they are small. A journey of 1,000 miles must begin with a single step. So let us gain insight on how to detect anomalies and screening fetus in first trimester with our esteemed speakers. I welcome you all again. Thank you.
So without a delay, we are starting our today's CME. I would like to invite our chairpersons for this CME, Dr. Vidya Tirankar ma'am, Dr. Raju Dabre sir. Dr. Tirankar ma'am is HOD at OBGYN department of VM Medical College, Solapur. She is a very good teacher, always ready to help and guide us. Dr. Dabre sir, he is a renowned fertility specialist and he is a great teacher also. Welcome sir. Over.
I request Dr. Sumit to start his
Good evening everyone. Let's start with the topic tonight. I'll be discussing about the nuchal translucency, some basics, and then we will discuss something more in detail about the NT scan. So, So why this presentation was made? Let's look at the scenario in our city when a patient comes for anomaly scan. We do around 8 to 10 anomaly scans per day. What I have observed is at the time of anomaly scan, almost 34% of the patients have not undergone NT scan. Whether good, bad, that's irrespective of that. Patients, around 34% of the patients have not undergone NT scan. That's like 1 in 3 patients, the NT scan is missed. So the window of opportunity for early detection of anomaly or of a genetic disorder is missed. So we need to focus more on the NT scans. Till early 90s, what we used to do is that in the 3rd month scan, if a patient comes, we used to look for the cardiac activity. If the heartbeat is there, whether it's there or not, that was the only thing we used to do in the 3rd month scan. And if the heartbeat is there, very good, patient goes back and comes back at the 5th month for an anomaly scan. But this gentleman, Professor Kipres, did a lot of groundwork, he did a lot of research, he published many papers, and then he changed the whole scenario, the outlook towards the scan which we do in the 3rd month. And now what we are doing during the 12-week scan is not just the heartbeat. We look for the ground rump length, we look for the NT, that is the nuchal translucency, we do look for the nasal bone, the tricuspid regurgitation, another soft marker, we look for the ductus venosus, we look for the intracranial translucency. It helps a lot for our open neural tube defects and dandy walkers, and there are many more things. But now today, as our talk is more on the prenatal screening and scans, we will focus on NT, that is the nuchal translucency in our talk today. Now let's start. What is NT? What exactly is this nuchal translucency thing? It is the actual anatomical structure which is seen as the translucency is most likely the normal skin at the back of the neck. To be more precise, a small but measurable amount of nuchal fluid can be identified in almost all the fetuses between 10 to 14 weeks of gestation. So when to look for it? Between 11 to 14 weeks of gestation or 11 to 13 weeks and 6 days as FMF has asked us to do. Between the crown rump length of 45 to 84 millimeters, and we should know that the NT increases by around 15 to 20% per week from 10 to 14 weeks of gestation. So now we know what is NT, we know when to look for NT. Now we will see why we are doing between 11 to 14 weeks of gestation only. So let's look at this case where the NT scan was done and her NT at 12 weeks was around 3.6 millimeter. We know 3.6 millimeter is high. We asked her to go for the testing. Patient goes for second opinion, goes for third opinion. She gets a scan done at around 15 weeks where the nuchal fold thickness is 1.9 millimeter. Patient has a pseudo feeling of well-being that the NT has decreased, and then they think that all is well. But in reality, all is actually not well. Why? Because to understand that, we need to understand the physiology, the physiology of the fetal circulation, the physiology behind the NT. Now let's look at this slide. In physiology, the placental circulation, we know at 11 to 14 weeks, only the first wave of trophoblastic invasion has occurred. So there is increased resistance in the placental circulation. Even in the fetal circulation part, there are going to be underdeveloped lymphatic channels. But after 14 weeks, when we move ahead, there is going to be the start of second wave of trophoblastic invasion. Then the placental circulation is going to improve. There is going to be decrease in the resistance, and from the fetal part, we are going to have the improved lymphatics. Now, this improved lymphatics in the neck region of the fetus, they are going to remove or going to drain away the excess fluid. So, the NT, which was 3.6 here, has become 1.9 because the excess fluid has been drained away. Now, why do we look for NT? If you look only one anomaly or one genetic disorder, that is the Down syndrome, NT alone done between the 11 to 14 weeks has got the detection rate up to 80%. So NT alone will help us to detect 80% of the cases. If we do NT along with our biomarkers, that is the PAPE, free beta HCG, our detection rate improves. And with the help of other markers like the nasal bone, the ductus venosus, tricuspid regurgitation, and adding our PAPE free beta HCG, that is the first trimester screening, our detection rate goes up to 93%, and with the decrease in the false positive rates. Okay, so this NT thing is not uniquely associated with Down syndrome only. It's not NT is not synonymous with the Down syndrome. We have other genetic causes in which the NT increases. We have trisomy 18, that is our Edward. We have trisomy 13, Patau syndrome, Turner syndrome, that is our XO. We have triploidy, we have Dijorge syndromes, and many other genetic causes in which the NT increases. In non-genetic, if we see, there are structural birth defects, that is the congenital heart disease, the diaphragmatic hernia, skeletal dysplasias, neuromuscular disorders also present with increased NT. Now, why this NT increases? We saw genetic, we saw the non-genetic causes, and we are seeing that the NT is increasing. So, why this NT increases in these cases? There is no single mechanism which is responsible for the abnormal fluid collection behind the neck of the fetus. In Down syndrome, the NT has increased because there is abnormal dermal collagen deposition, while in cases of our Turner syndrome, there is abnormal nuchal lymphogenesis. We all know they have the defect in the lymphogenesis. In cases of heart disease, the fetal heart diseases, it is the cardiac dysfunction and the aberrant endothelial development which causes the NT to increase. While in cases of skeletal dysplasia, the narrow thorax, the mediastinal compression leads to collection of the fluid behind the neck. Okay, now we have seen what is NT, what are the benefits of taking NT. So let's see how to measure this thing correctly. First and foremost, the fetus should be in the mid-sagittal plane. No parasagittal plane is acceptable. Mid-sag, your orbit should not be seen, your zygoma should not be seen. Head should be in neutral position. There should be no flexion or hyperextension. There should be pocket of fluid visible between the chin and the neck. That means the fetus is not in the hyperflexed position. The crown rump length should be between 45 to 84 millimeters. We saw the reasons just a few slides back. Now about the machine. Whenever we are placing the calipers, our machine should be able to adjust the calipers for the increment of 0.1 millimeters. Image should occupy 75% of the screen space. Furthermore, only the head and the upper thorax of the fetus should be visible. We are not interested in the rest of the body while we are measuring the NT. The margins for the NT should be clear. The lucency, that is the anechoic area, is measured perpendicular and in the widest space. Do not measure it over here, do not measure it over here, measure it in the widest space. And calipers are placed at the inner border of the lucent lines. We will see more about this. Measure more than once and report the largest measurement which is meeting the criteria. Now this is about the caliper placement. Now consider these two gray lines to be the margins of the NT, and this is the correct caliper placement where we have placed the caliper from inner to inner margin. Now we sometimes do encounter a nuchal cord at NT scan, which is seen in around 5% of the cases. Then when there is a cord present, how do we measure the NT? So the measurement is taken above the nuchal cord, is taken below the nuchal cord, and we take the average of these two readings. What are the fallacies, or when do we get the false high NT? We have to take care that we do distinguish between the fetal skin as well as the amnion. Like in this case here, if we see, it seems that the NT is increased, but if we wait and just allow the fetus to move, we can appreciate by the fetal movements that actually the increased NT, the image which looked like an increased NT is just the amnion, and the fetus has moved, the amnion still remains behind, and so the NT in this case was very much normal. It was just the amnion which gave us a false impression of increased NT. So just wait for the fetal movements, and this will help us distinguish the things. Now how do we take NT in obese patients? Again the same problem occurs in obese patients, that we are unable to distinguish well between the skin and the amnion. So what we do is some tips and tricks we can use is we can examine the patient in the prone position where we can actually appreciate the NT well, or we can even examine the fetus in the BPD section where the fluid levels can be seen very well behind the ossicle. So these tips and tricks do help us in obese patients, and transvaginal examination of course is a boon in such cases. How to measure NT in these cases? In this case, we are just going to counsel the patient, explain her that the fetus is not in position. We are going to ask her to wait outside, see her after some time, because this is actually not the position in which we can do anything. So patient has to wait, let her bladder fill, let the baby move, and after some time we can reassess her. What about NT measurements in twin pregnancies? So NT measurement has been validated as a very effective tool for aneuploidy detection in the dichorionic twins. detection rates in the DCDA twins are comparable to those which we obtained in the singleton pregnancies. However, it is a less reliable marker for aneuploidy detection when it comes to a monochorionic pregnancy, and the reason being that the increased NT or discordance in NT is an early manifestation of twin-to-twin transfusion syndrome. Now, what are the differential diagnosis of high NT? Let's just keep in our mind that a posterior encephalocele, occipital encephalocele, what we may see in a Meckel-Gruber or cervical meningocele, cystic teratoma, the hemangioma at the posterior aspect of the neck may mimic increased NT. Now, this is a busy slide, but we have to just focus on the circles. So, when do we call in NT as an increased NT? First criteria is about the 95th centile. Let's look at this case. The patient is around 13 weeks pregnant. Her NT is 1.8. So, it is very much within the 95th centile. Whereas, another case where the gestational age is 11 weeks, NT is again 1.8, same thing, but in this case, as she is only 11 weeks pregnant, the NT is going above 95th centile. So, in this case, it is an increased NT. Do we consider NT to be increased when it is 3 mm or 3.5 mm? What should be the cutoff? The faster trial says NT, if it is more than 3 mm, it has got a high risk for aneuploidy, up to 1 in 6 cases, and there are minimal benefits for waiting for the serum results. But this criteria of NT being more than 3 mm as cutoff should be taken only in cases where the strict protocol for NT measurements have been followed. Otherwise, NT more than 3.5 millimeters is anyways abnormal, that because it falls above 99th percentile irrespective of the gestational age or the CRL of the fetus. So what do we do if we find that the NT is increased? If the NT is more than 3.5 millimeters, we do go for invasive testing in form of chorionicular sampling or amniocentesis if the patient comes to us after 16 weeks. And previously we used to do karyotype, but nowadays a microarray is the preferred test over the karyotyping. We will see the reason why. And once these microarray reports come normal, we have to go for the second step, that is our anomaly scan with echo. Now, why we have to go for an anomaly scan, or why we emphasize much on anomaly scan with echo? Because even with a normal microarray report, there is around 29% risk of pregnancy loss or there being a structurally affected fetus. The fetus might have some cardiac anomaly or some evolving skeletal dysplasia. So we have to emphasize on anomaly scan along with echo once we get our microarray results. Now, what are the fetal outcomes with increased NT? If the NT is between 3.5 to 4.4 millimeters, the chances of karyotyping abnormal is around 20%. 1 in 5 case will have abnormal karyotype, as against the normal outcome can be expected in 74% of the cases. As the NT increases, the abnormality in KT increases and the chances of having a normal outcome decreases. So the more is the NT which we see, less favorable is the outcome. Now, what is the role of microarray? This test, madam will be discussing more about this in her talk. But what is microarray? It's a test to look for the submicroscopic chromosomal abnormalities. In karyotype, we look for the chromosomes. In microarray, we look into the chromosome a little more into the depth. That is, we look for the microdeletions, duplications. Why have we switched over from karyotype to microarray? Because microarray is going to give 5% increased diagnostic yield as compared to the conventional karyotyping, and even the turnaround time for the results have decreased. The results of microarray are available within 2 weeks time period as compared to 3 weeks time what labs take for the conventional karyotyping. Now, this is just a karyotype report for us to know. This is ideogram, it's said and called, and here we can see this is a case of a pure trisomy 21, where we can see the 3 copies of chromosome number 21. So it's a pure trisomy 21, a fetus with Down syndrome. And here we have a microarray report. Now, when it comes to genetics, even sky is not the limit. From conventional karyotype, we have moved on to microarray, but again we have further tests, in-depth tests, and those are called exome sequencing. We have clinical exome sequencing, we have whole exome sequencing. So the question comes whether we should be doing the fetal exome sequencing in cases of isolated increase NT. Patient says, I have pots of money, you do whatever test you want to do. So should we be advocating or advising them to go for the exome sequencing? And the answer given by this paper in 2021 is that the diagnostic yield is low for isolated increased NT when we are doing fetal exome sequencing. It's an expensive test, the results are going to take good 5 to 6 weeks. So as of now, we are not counseling patients to go for a clinical or a whole exome sequencing in cases of isolated increase in the NT. Now some commonly asked questions are, how do we take NT? Should we be doing the scan transabdominally or transvaginally? It is left to the discretion of the sonographer, or more so it is left at the position of the fetus. If the fetus is in the position abdominally, you take it transabdominally, or even transvaginal scan is fine. Should we be doing the scan with full bladder or empty bladder? Again, it depends on the sonographer's comfort. How do they do? We prefer to do with empty bladder, because in case the fetus is not in a position transabdominally, quickly we can go ahead and do the transvaginal scan. Next is whether we should be doing at 11 weeks or 13 weeks. I prefer to do it at 12 weeks, and even Gandhi sir and Davde sir will agree that 12 weeks is a decent time period to do a NT scan, because you see the fetus anatomy well, the fetus doesn't jump too much, the nasal bone, the cardiac things can be well visualized at 12 weeks. How to excel in NT scans? This Fetal Medicine Foundation has got a very good lecture series. All of us should attend. All of us should attend this course, which is of around 3 to 4 hours. We should give an examination. They have an exam at the end of the course. It is all free of cost. And once we have done the certification course, we should start doing NT scans in our own clinic whenever we have a patient and our time permits. So again, the same thing, we need to have adequate training, we need to have good instrumentation, that is the USG machine, and should be able to give sufficient time to each. Now, this slide I have purposefully put to discuss the cases where we should not be doing the marker test. I know this conference or this meet is to promote the marker test, but these are the indications which we do see in routine life or a day-to-day scenario, where the double marker, triple marker or the quadruple marker tests are being asked to be done. So these are few common indications where the double marker or the quadruple marker is not the answer or is not the solution. For example, in presence of a fetal structural anomaly, an NT scan, you find an encephaly or we find a spinal dysraphism, please do not do a double marker test. We do get cases where the lady has a previously baby who is mentally challenged or is mentally handicapped or is having cerebral palsy. Previous baby with cerebral palsy, kindly do NT scan along with Down syndrome testing, along with double marker. Understand one thing, child which is mentally handicapped can be because of various reasons. Down syndrome is not the only cause for mental handicap. We need to do a genetic counseling, we need to see the cause why this baby was mentally handicapped, so that we can help the lady or help the couple in this current pregnancy. One another common thing in our city is consanguineous marriage. Couple is consanguineously married, so a double marker test is being asked for. No, double marker test is not to rule out the single gene disorders out of consanguineous marriage. Double marker test or the first trimester combined screening test is for Down syndrome. Again, this is the question which is asked by the patient and her husband. आमचा blood group एकच आहे, double marker करू नका. Again, not the indication. Same blood group of the couple is not the indication to do double marker test or any screening test because the screening test is basically for aneuploidy detection. Thank you.
Thank you, sir. That was a very good talk. Any questions? Okay, just for the benefit of
Just a
everyone.
question.
Any?
Why is it not a routine for every patient to offer them double marker medically also? If
Sorry.
we don't advise, they will not do.
See, the
Every
ACOG
year-
guidelines say that all patients, irrespective of the age, whether she is advanced maternal age or she is of 20 years old, all pregnant women who has undergone an NT scan should undergo a first trimester combined screening test. So that is the guideline. But here in our country, because of the financial constraints, many patients they do not opt to undergo double marker test because it costs around 1.5 to 2,000 extra over the NT scan. So it is like spending 3.5 or 4,000 rupees for a third month pregnancy, which is not practically feasible for all the couples, at least in tier 2, tier 3 cities.
So she wants to know medically, is it sound okay to not to advise this marker?
Yes, if a NT scan is good, if I see that the fetus is structurally normal, if I don't see any soft markers which we have discussed, I am fine if a lady is not undergoing aneuploidy screening test.
What
I do
suggest
not
is
force.
we should advise, they should refuse, we can write that patient is not ready. But if there is something goes wrong and you have not advised,
But you have
against
written
us
it on your
in the court
paper
of law.
that you had advised. See, that's the discussion we had in the last meeting also when sir was there.
Yes, I will answer your question. See, point number 1, you have right to decide your own protocol. We don't have any guidelines in our country. Am I right?
Yes, sir.
You have right to decide your own protocol. NT, NB and DV, if you take 3 parameters, you have a detection rate, if you do a good scan, 90%. Am I right?
Yes, sir.
If you add a marker, a good marker, I say a good marker, then your detection rate or the sensitivity increases to 95%. So you are adding additional 5% by doing a good double marker. Now the problem in our country is about the quality of the double marker test. There are a lot of stringent criteria to be followed to have a meaningful values of the double marker. Unfortunately, I haven't found any lab which is doing so. I have tried many labs and finally I have stopped doing those markers. I clearly tell the patient that my risk calculations are dependent on these 3 parameters and my audit says that it is a 90% detection rate. So that way it goes. You have to decide your protocol. If you can't do the NT, if you don't have the facility of doing the NT, do the double marker, but then you tell that the sensitivity is 70%, out of 10 downs, I am likely to miss 3 downs. You have to conciliate clearly to the patient that this test has this limitation. I do a quadruple marker, but then I have to tell the patient that 4 out of 10 patients will be born downs in spite of having a negative quadruple. That way it goes. We need to conceal the test which we are doing to the patient. Now my question to you is, you had a 34% previously done.
So the patients who come to
Your
clinic.
second trimester scan.
Yeah, so we do it
30% of 34 or 36%.
Yeah, 34% of the patients, 1 in 3, they have not undergone an NT scan. Yeah.
Those who have undergone the NT scan, have you applied the Harman score? And how many of that you found that those are the validated NTs? Are you sure that all 34% are properly validated entities?
No, the 34% of the patients had not undergone the scan.
So
we are
that
not
means
talking about the good scan.
66% had
Have
undergone
a
the
NT
scan.
scan. Have a documented NT scan.
66%, how many of them, after applying the Hermann score, validated that those are...
No. Because
I think
if
that
I
is-
start doing that, from next day, I think I might not be getting half of the patients again. If I call up the doctor saying that you have not done a decent work, then I'm being frank. I can't teach you that how to do a NT scan. You are sending patients to me, I do the scan, I send back the patient to you, end of the story. That's how it works.
That is, and coming to the point that when you see a combined screening report, you must look at the images. All of you must be knowing the Hermann score. Hermann score is a 10-point score. Magnification to, neutral position to, mid sagittal position to. If you see the membrane and the amniotic membrane too, that way it goes to 10. So you apply this score. If your image, which is provided with the NT report, gives a score of 8 plus, then it is a valid NT scan. And if that NT measurement has used in the double marker screen or the combined screen, then the whole report has a validity and meaning. Otherwise, it's a useless exercise. And that way I do it. Where the Hermann is applied, if it is 2 and 4, you see a small fetus, a small marker, caliper put somewhere and the NT is written and that is used with the double marker. That is just a useless investigation which has, if the baby is born after Downs, who is responsible for such tests? That's the thing.
Would you advise termination only with increased NT?
No.
What
No,
levels?
absolutely no.
No, means first answer is no. Yeah, if there is isolated increase NT, no. But if there are other associated things like there is a cardiac anomaly, cystic hygroma, anasarca, then the outcome is not good. But yes, even with isolated increase NT, when we tell them about the test needed, the CVS, the cost associated with it, I have seen that many patients, they do terminate irrespective of the amount of counseling a fetal medicine person has done and the obstetrician has done. So this is how it works. Still today, that patients, they just go and terminate the pregnancy.
That was a nice presentation, Surya. Thank you very much.
Thank you.
So good evening to everyone. I thank the Oxcani Testing Oxcani Society for having given me an opportunity to speak on the latest trends in genetic testing. In the
Just check with the mic.
थोड़ा और ऊपर करना।
So thank you so much for giving me an opportunity to take us through, take us through the brief overview of genetic testing in the Oxcani segment. Of course, I will also mention a couple of things which are off the Oxcani as well, but this is what the trend is and how best the genetic testing could be helpful in the scenario. So just a brief of the contents of the presentation. I will be taking from the current trends of genetics and genomics, the broad overview of genetic concepts and the diagnostic technologies, and what is the role of the diagnostic lab. Hello? Yeah. So what is the role of the diagnostic labs in this arena? A bit of the genetic counseling, the important factor again here with the patients, and few case discussions which would enlighten why we should be looking at the clinical indications of the patient and suggest the respective test. It is not always needed that you need to go in for a very high-end, like genomic testing, as Dr. Sumit also mentioned, whether we should go for an exome or no. So depending on the clinical indication, it is helpful that we bring the genetic testing, menu to the patients. A little about Metropolis. We are an NABL and accredited labs the diagnostic tests. So basically Metropolis is known for the pathology, segment over there, which includes the hematology, genetic and oncology as well. We've got the state-of-the-art technology, the marker screening test on an FMF accredited platform. And in the NGS arena, we have just come up with NIPT in the last 1 year, and we have also got into breast cancer mutation testing. And the high resolution HLA typing and lung cancer and pipeline, and a little about the genetic counseling. So high resolution HLA typing came into the picture because we got a lot of requests that in the IVF segment, when somebody wants to go in for a PGT or PGM, they would also want to do the HLA typing of the right embryo, so that this child could be a prospective donor to the affected child of genetic disorders. So we've got these different scenarios on the gynec expert, oncomed, micro expert, and genome expert. These are just our fancy names to include the kind of testing for the women and child health in oncopathology, chronic and infectious disease, and molecular genomics. So a little about the ever-changing state of technology has always had a very deep impact on the medical community, from the diagnostic and the medical community. And we see that diagnostic labs are a bridge between the technology and healthcare. Every year we come across, and it's very imperative to keep pace with these kind of technologies and the literature, because we see that every year we are seeing some kind of papers which are talking about, inclusion of some genes in a particular disorder. So today I may talk about intellectual disability in a child or a GDD case. I know that there were initially just 3 or 4 genes which were responsible for the testing. But as of today now, there are a group of genes which are involved over here. And the data is enlarging because earlier NGS was not into the picture. Now when it has come in there, we are now getting a lot of these literature and study reports which enlighten or which bring about the different genes in the picture. Of course, as Dr. Sumit also mentioned that it's an expensive test, and which is why I would be just taking you through in the next slides to highlight why we should be doing exome in particular cases and why we should be doing microarray in certain cases also over here. This is just a slide to show that the kind of the technology changes right from 1977 when we started with the PCR and Sanger based technologies to look at the genetic variants or the mutation testing. And today, beyond 2019, we are already into the 3rd and the 4th generation sequencing. Any molecular lab would have these kind of basic technologies, right from the basic PCR, which is for a targeted mutation testing. So let's say if I have a case of beta thalassemia, I would just want to do a simple PCR test rather than going in for an NGS based test. If I have, if the common mutations or the common aberrations that are seen in a particular disorder cannot be picked up by targeted mutation testing, then I go in and sequence the entire gene. So that's where Sanger sequencing comes into play. Microarray is now, according to the ACMG guidelines also, it is a first tier testing. So basically either a karyotyping or a microarray would be the first test of choice, followed by the next NGS or the other methodologies. So yes, it's a gene expression profile, and this needs to be, it's a test of choice as of today. NGS, we are looking for genetic variants when we want to test for multiple genes. That's how NGS comes. So basically, Sanger sequencer and NGS has just one common thing in them, is that when you do a Sanger sequencing, we are only looking at one particular gene. But when I am doing multiple genes, that means sequencing of the genes are done at one go. So we are not subjecting the patients to do a mutation testing and maybe say gene A and I didn't get anything. Now we do a gene B, which increases the sequential cost to the patients. So it doesn't make sense doing it in a go. So it's better that we do sequencing of all these genes together by an NGS technology. Then MLPA is another technology which is basically looking for deletions and duplication. So suppose if I had a case of a child with Duchenne muscular dystrophy or spinal muscular atrophy, we know that the genetic variant here is an exon deletion. So then I don't want to go and do other testing, but I would only do an MLPA test. Coming to the last one, this is the fragment analysis, wherein we look at these ataxia cases, where we look at the repeat, expansion. So these disorders which are caused due to triplet repeat disorders. So maybe an ACC has been repeated n number of times, and when I want to look at it, I go for the fragment analysis. These are some of the pictures that any molecular lab would have. They would have a thermal cycler, they have a Sanger sequencer, and now we have a NGS-based platform. So in the genetic offerings in the gynec and the IVF segments, we have the antenatal testing as any other lab has, the serum marker test, the NIPT, and an invasive technique, so prenatal diagnosis using, with the invasive mode by doing testing on the CVS or the amniotic fluid. Then we have couple karyotyping, FISH for common aneuploidies, Y chromosome microdeletion. So basically TB-PCR, Y chromosome microdeletion, and a couple karyotyping are the test of other panels which one would look into the infertility segment. Prenatal diagnosis of genetic disorder, and in the postnatal segment we have microarray, which is basically much better for for samples like products of conception, because your karyotyping fails in more than 95% of the cases. It involves cell culture, and because of the nature of the specimen, karyotyping is not a good choice. And as Dr. Sumit also mentioned, we have about 5 to 10% more information or a diagnostic yield as compared to a karyotyping test. Yes, and in the last one, the evaluation of genetic disorder in index child. Now, this is something very important, as we know that subjecting somebody for a whole exome testing doesn't make sense if I didn't know the genetic variant in the index child. So once I know the variant in the index child, that's how I can extrapolate it to the subsequent generations. In the genomics, as I mentioned, NIPT BRCA testing we are already doing. HLA and onco especially in the lung cancer panels. So we now there are reports wherein you can also do testing of maybe just 12 genes for lung cancers by using cell-free tumor DNA. That means we would take the maternal the patient's blood and isolate the cell-free DNA from it, and then look for the sequencing of those 12 genes. So basically, I mentioned this because we're looking for a smaller, testing panel, trying to make this a little more cost, effective for the patients as compared to a whole gene testing. We have the ones which are highlighted in blue are the endometrial receptivity assay, which is a new test. Actually, not a new test, but now there has been request whether we should be doing an endometrial receptivity test in cases of implantation failure cases. And then PGTM and PGTA, PGTSR. So structural aneuploidies and monogenic disorders are the ones which are asked for or requested for in the IVF segment. Carrier testing, which is an egg donor, this is basically a good test for the egg donor because it's practically not possible to look for all the genetic disease in a donor patient, right? So if there is a combination of the very common type of disorders that one actually needs to look at, there is a NGS-based panel for the egg donor. So basically now the trend that we are noticing in the last 1 year is, along with in the infertility zone, along with the routine panel of testing like Y chromosome, sperm fragmentation test, or like a TB-PCR for and couple karyotyping. Carrier testing is now getting into the picture because they want to ensure that the donor is free of at least the commoner genetic disorders. These are the areas that we come across from menarche to menopause. The kind of challenges that one faces are the preconception, prenatal diagnosis, infertility, cancer, infections, genetic disorder, or a recurrent pregnancy loss. So what has changed from in the last couple of years was invasive to non-invasive. Of course, this is again, invasive happens to be the gold standard, no doubt about it. But when we come to look at cell-free fetal DNA, be it NIPT or be it cell-free or a lung biopsy, if we have to do a cell-free tumor DNA in a routine sample, then these kind of non-invasive techniques are just coming into play. Of course, the trust and the awareness is most important, and the choice of the test with the patient and the doctor. So NIPT and aneuploidies, single gene disorders. So these are the three areas which are now moved into the non-invasive arena. And in the invasive, of course, it has the highest, in fact, the best diagnostic value, one would say. And even with the non-invasive tests like NIPT, any high-risk NIPT test always needs to be confirmed by an invasive technique. So although it has the highest accuracy, but it still needs to be confirmed by an invasive test. This is a slightly older slide where I put in the detection rates and all, but today, as Dr. Sumit's slide that we saw, more than 93% is the accuracy rate with the kind of biomarkers added to it. But with NIPT, the common trisomies like 13, 18, 21 and the sex chromosomal aneuploidies have a accuracy rate of 99%. Here when I mention 99%, 99% is for trisomy 21, which is followed by trisomy 18 and 13 and the sex chromosomal aneuploidies. But we know that the most commonest one is the trisomy 21, and hence NIPT happens to be the has the highest accuracy for those cases. It's usually done in the lab with two different tests. It has one which is a basic NIPT where we look for the common 3 chromosomes, aneuploidies, and sex chromosomal aneuploidies, which would be like for Turners and Klinefelters and triple X. In the next gen advanced, we have the commoner ones along with the autosomes. So basically, although there is a perception that some labs give the reports of all the chromosomes together, but honestly, looking at the frequency of the autosomes, we come across very rarely such cases. Like when I was doing chromosomal microarray, I came across only trisomy 2, 5 and 7 in a span of 5 years. So if we actually look at even if we look at the incidence of it, the autosomal aneuploidies are less commoner as compared to the common 13, 18, 21 and the sex chromosomes. So yes, the choice is either we go for a whole testing, all chromosome testing, or just want to choose between the common 5. But it can be done as a combination too, definitely. This test is offered between 10 weeks of pregnancy, so the test can be done until the end of the pregnancy. However, usually we recommend that they do it between 17 to 18 weeks, so that there is some room for invasive testing in cases of positive or high risk results. The testing platform that we are using here is the Iron Gene Studio, which is so today, although there are many players in the market for the NGS, what most frequently the labs are using are the Iron Torrent platforms or the Illumina platforms. I get a lot of these queries, from some of the doctors saying that why, so we are using the Torrent one at the moment, and then why are you not using Illumina? Because that's the most, that's the latest in the trend and that's the best. But I need to bring it over here that with the smaller panels or with the NIPT testing or smaller panels that we've already, which I listed in the first slides, these are as comparable with that of an Illumina. Illumina platform actually looks at the deeper coverage of the gene. If you actually want to look at the whole genome or a whole exome, that's where, because it has a higher depth and a greater coverage over there. But if you have to look for the commoner panels, Iron Torrent is an equivalent platform. So these, everybody knows about it, but yes, just listed over here that advanced maternal age. Many a times, there are no indications, but just because the lady has an advanced maternal age, we have seen the trend. Whatever I have listed here are the kind of things that we have encountered in our labs. So many a times I get a requisition which only says advanced maternal age. I speak to the doctor and ask for some more clinical indication that was it a high risk dual marker, or are there any other sonological abnormalities. But they say that no, or maybe many a times if the lady has had a previous affected pregnancy with a Down syndrome baby, she wants to be like sort of 200% sure and wants to do a test. So although we do mention that there should be some do's and don'ts, but we are seeing the trend changing this way as well. It's not suitable for women under medical conditions like cancer, chromosomal abnormality, because it is known that these cells are a lot of chromosomal imbalances are seen in the tumor cells over there, and hence the test results could be confounded and we may not get a conclusive or a right result over there. Multiple pregnancies, the test is usually validated for twin pregnancies. Beyond twin pregnancies, it's a little challenge because there are multiple sources of fetal DNA, and that could sort of mask the results. So most of the tests we see are validated on twin pregnancies. There's another event which is the vanishing twin pregnancy, wherein there's been a fetal reduction, let's say in the first trimester, and the lady wants to do an NIPT. We do request them to wait for a gap of 6 to 8 weeks, because at that point of time, the circulating fetal DNA from the redacted twin is expected to be, like mellowed down. This is just a small little picture of how we go about doing NIPS, but here I need to put that when we take the sample of the mother, there is maternal and fetal DNA that we isolate together. So how do we ensure that what we are doing is just the fetal DNA, that the answer that is there? So we've got like a DNA extraction from the blood, and the library preparation, doing a sequencing and having a computed report by doing a whole genome sequencing on all the chromosomes. So basically there is a threshold which has been set with the computational the scores that we get out of the sequencing. So anything, so this is a combination of the mother and the fetus. Anything that crosses this is called trisomy. So there are scores for monosomies, there are scores for trisomy. So once we cross this level, that's how it is like reported as the trisomy. This is the kind of report that we have. We mentioned the background risk. This could either come from the dual or the quadruple marker, or from any other. So dual or the quadruple marker. These are the reports we mention for the high risk for which chromosome over here. We do mention a score out here, and these are the reference ranges of the score. Depending on the score, we call it a high risk or a low risk pregnancy. So these are the these are the different technologies that every lab so before joining Metropolis, I was in Lilac Insights, and there we were using the TAX technology. So these are all different ways of looking at the genome. At the moment in Metropolis, we are using the whole genome sequencing. So all these three techniques are comparable, and just it is that some of the in-depth kind of sequencing that we need to do is looked at by doing a whole genome sequencing. So this and the TAX technology happen to be good, methodologies to look for an accurate NIPT report. So the USVs are basically the non-invasive. The platforms that we are using is Gene Studio. Accuracy for common trisomy, especially with trisomy 21, and the sensitivity for trisomy 21 followed by 18 and 13. This is our NIPT data, wherein we have looked at 50,000 women who have undergone dual or a quadruple marker. We found a 4% positivity by any of these markers, and that we found that when these women, these 4% positive cases, when they were subjected to NIPT, at least the ones who chose to do an NIPT, we found that 90% of it did not have to go in for an invasive testing. So initially, before the NIPT came into the picture, it was like anything that was high risk on dual or quadruple used to go in for an invasive. So of course, invasive has its own challenges, although a very small risk, but yes, it does have. So, these 90% of these women didn't have to go in for an invasive. And I am saying this because in our data, we did do personally an end-to-end correlation. So we wanted to see if a dual marker positive and an NIPT positive was it actually positive when we went ahead and did an amniocentesis. Because that's how I get my confidence of the test, and also the answer whether we should be doing NIPT or we should not. Because at the end of the day, dual marker and NIPT both are screening tests. So it might happen that, okay, the patient might feel I'm doing a dual, I'm doing a NIPT, but you're just still calling it a screening. But when I did an end-to-end correlation, I found that, with the small number, of course, 1500, now we have crossed about 1800 or so. Whenever I did an end-to-end correlation, I found that, there were, the concordance with trisomy 21, 18 and 13. Of course, we had one sex chromosome result which was discordant, which meant that the NIPT result was high risk for sex chromosome, but when they did an amniocentesis, the fetus was found to be normal. Unaffected actually. So that's why we feel that, so in my own data, I would feel that sex chromosome has a little lower accuracy as compared to the other three chromosomes. So now a question of whether NIPT really replaces antenatal marker screening, this actually just comes with scientific evidence and patient awareness. So this answer only a doctor can give. The other genetic test that we are talking about here is like basically karyotyping in fish, as I said, the gold standard, microarray because it gives little more information. But yes, there are pros and cons of everything. Like what we would get here, a balanced translocation could have been missed by microarray, which can be picked up by karyotyping. So of course, all the techniques, we will never get an answer, a 100% answer on any of the techniques. There has to be some, glitch here and there. But yes, microarray, as Dr. Sumit also rightly pointed out, is a very good test because it also picks up genetic variants in consanguineous marriages. So if we actually look at consanguinity, the kind of the genetic, material which is either a loss or a gain, which we call a deletion or a duplication, is actually very nicely picked up by chromosomal microarray and a good test for a product of conception. And then we also have this carrier screening and prenatal diagnosis, as I mentioned, for beta thalassemia, sickle cell disease, cystic fibrosis, and Duchenne muscular dystrophy. Microarray, as it mentions, that submicroscopic imbalances which we can pick, that means the microdeletion duplications that we can pick over here, and there's a high resolution assessment of the entire genome. So why would we choose, or when would we choose a microarray? We would do it in an unexplained GBD or an ASD case or a multiple congenital abnormality. So these are the areas where we should actually look at microarray and not the other techniques. Good for POCs, but can also be done on a CVS and amniotic fluid. This is just a pictorial depiction of what the deletions or duplications are all about. So anything above the thresholds are a gain of the genetic material, which is called duplication, and anything below the threshold is the loss or the deletions. These come with array-chrome and array-feto. These are the areas where we do the chromosomal microarray on the POC or the fetal tissues, and for these cases we also provide genetic counseling. So many times they do come down, recurrent pregnancy loss, or they come down with a report saying it's a triploidy. So we need to mention to them whether what is the recurrence rate, or whether this kind of event would happen one more time. So genetic counseling is offered for these cases also. A little about endometrial receptivity assay. Of course, this was there for long, but what it means is now what they are doing is they are trying to find out whether whether the endometrial was a culprit or was it a good embryo quality. So there has been a debate between the faulty endometrium or a faulty embryo, good quality embryo. And because of the implantation failure, they do say that probably this could be a good case. I am not saying this at the moment because there are very different studies which go in for or against the endometrial receptivity assay. I have mentioned this over here because this is an upcoming test. And what actually it does is they test endometrial biopsy and look at the expression of the variable genes. Like it mentions over here, they look at about 238 genes, and then using a computational predictor, a personalized window of implantation is assessed for the patient. So in the next cycle, that window of implantation, whether it's that 4 or 6 hours, that is the time which is the best time for an implantation. So that's how it's a personalized WOI is generated for these patients. Coming to pre-implantation genetic testing, of course, PGT-A means chromosomal aneuploidies, PGT-M means monogenic disorders like thalassemia, cystic fibrosis, Fragile X, and SMA. So these are also carried out on an NGS platform. It becomes easier to assess all the chromosomes at the same time when we are looking for the aneuploidies. Carrier screening, as I mentioned, a good test for egg donors because they are looking at about 418 genes which actually takes care of these commoner disorders. So as I said, practically not possible to, unless there is a family history, it's not possible to look at everything at one go, which is why these disorders are combined and about 418 genes are tested at the same time. And what more, there is so much more in literature that talks about now these novel molecular biomarkers. Of course, these are all in their R&D stages, but it means to say that even today, sperm telomere length is looked at and assessed, or related to a male infertility case. There are some markers which are basically, for carrier females of a Robertsonian translocation, or there are some GP6 gene polymorphism which are related to recurrent pregnancy loss. Of course, these are all under study, and once these are associated, these could be the next markers, and we may not have to go for a very high-end testing. Little about genomics. We have about 20 to 25,000 genes, of which 5,000 are the disease-causing genes. When we are studying a single gene, I call it genetics. When we are studying complex diseases or multiple genes, we call that genomics. In this slide, I'm trying to say that, of course, the genomics is catering to, looking at the genetic variants in a particular disorder. But at the same time, we are seeing that the trend is moving from illness to wellness. We get some patients just coming to us and asking for a whole exome sequencing. And I do ask them that, why do you want to do such a high-end test? Do you have a family history? And they say, no, just my father had, he was hypertensive and mother has diabetes and I just want to do this. So I said, but what are you going to? So they tell me, and today we know that many patients are, rely on Google, and even I do so, honestly, because it is helpful, like at that point of time. So basically, it moves to the wellness segment because today they know that there are predictive markers. If I did an exome testing, there are some predictive markers which might help me, enter the treatment modality at an earlier stage than waiting for the disease to manifest. So next generation sequencing, as I said, why do we call it exome? Because in a gene we have, these are the exons, the orange ones are the exons and the blue ones are the introns. So basically we see that the genetic variants, more than 85 to 90% are seen in the exons. And that is why instead of screening the whole gene, we screen only these areas of the genes. And that's why it is called exome sequencing. There's a slight difference between exome sequencing and clinical exome sequencing. Because in exome sequencing, finally, in both the cases, we are looking at genetic variants in the exomes. But in clinical exomes, only those particular genes or the hotspots are checked for looking for the genetic variants. But if somebody wants to do a whole exome sequencing, not to miss out on something, then that is also carried out. A whole genome sequencing is done, but that's it's on a very, research and development, as one would say, just to know, okay, if I did do an exome and if I did a genome, am I missing out on something? So, but right now, clinically, these are the test of choice once we don't get an answer on microarray, and if they've had a strong history over there. And then we have some targeted panels. Say, for example, if somebody wants to look at cardiomyopathies, then why do an entire exome? We could just have a list of those 12 or 15 genes and form targeted panels only to look for cardiomyopathy, or maybe say skeletal dysplasia or any neuromuscular disorders. I'll skip this slide. So these are the different types of NGS panels. Just listed some of them, but these are the panels that one looks for. Like for example, many a times BRCA patients, we just look for BRCA1 and BRCA2 genes, but we realize that sometimes only testing the tumor biopsy, a somatic mutation analysis can be done. So this happens in the oncology segment. Coming to the gynec segment, we have these muscular dystrophy and congenital myopathy gene panel. So this takes care of all the muscular dystrophies listed so far. Then we have the neurological segment and an HLA typing to look for the thing. Genetic counseling, as I mentioned, is the most important component over here. I'm sure the doctors are doing a brilliant task by actually counseling their patients. But sometimes, for a group of patients which require more attention, right, to start from what a chromosome was. So somebody got a report like triploidy, and they need to know, first of all, what is a chromosome? It starts from that area. And then when they need a very extensive kind of an explanation, that's how we get into the picture. And here what we do is basically just to brief the patient with the limitation or benefits of whichever test that they have selected. We do explain them the test results, because many a times it happens they paid a good amount for the test, and at the end of it, suppose they get a negative result. So it's very important to brief them that why we are looking for, what are we looking for, what are you going to expect in return. And if you get a positive variant, then how does it help your subsequent pregnancies. So it is very important to explain them the limitations and benefits, and provide the risk assessment and genetic predisposition in case of positive results, and suggest them the preventive and the management options. We do it at the premarital stage, the antenatal and the postnatal cases. So basically here it is the most important counseling that happens, because here we are looking at the index child, and that's going to be very important for us to look for the later family members. These are the flyers that I have. So I do a counseling here in Mumbai We also have Dr. Aparna Rajendra who does the counseling from US for certain patients who actually need a little more in depth. And for in the Indian population, I mean in the Indian countries, I do the genetic counseling. This also happens in the via personal one-to-one or maybe on a video call. So we do explain, and these are the flyers that I put across. Right, maybe what the gene is, and what are we looking at, what are the chromosomes, 2 copies or 3 copies are going to indicate what. These are the when you are doing the prenatal testing, how is it done, at what stage it is being done. A little about autosomal recessive. So if somebody has had a affected pregnancy and it's an autosomal disorder, then we do tell them that there is a 25% risk in each pregnancy. So that has to be sort of brought to their notice, and whether it's an autosomal recessive or a dominant disorder. So just 2-3 cases quickly to highlight, the reason being that what was the indication and what was the test suggested. So the first case was beta thalassemia. So on a routine antenatal screening, she was found to be positive, and so the spouse was asked to be tested for beta thalassemia. He was also a carrier. We explained the 25% risk to them, and a prenatal diagnosis for the current pregnancy and testing of family members was suggested. So now this is something that on a very simple HPLC, they were found to be carriers. We did explain them the inheritance, and a simple PCR was suggested because the parental mutations were first looked at, and the same mutations were looked into the fetal DNA. So this was a very simple testing that we had to do, and we did tell them that you just need to be. So we told them that that the parental mutations are important to be done because it's an inherited disorder, and there's no point in looking for a lot of those 50 or 60 mutations that are seen in the Indian population. The case 2 was spinal muscular atrophy. Again here, we know that the culprit is the homozygous deletion in exon 7 in the SMN gene. So we do explain them that, well, this is a normal motor nerve, and this is an affected one. So you see the atrophy, they're seeing a little less lodging in the cell membrane, and this is what your child is suffering from. Again, we do tell them that this is an autosomal recessive. So every time, every pregnancy will need to be tested for the disorder. And here we chose MLP as a test because here we are only looking at deletions and duplication. So between this threshold, this area is a normal area, and below the threshold was the exon deletion. So just by doing this simple test, we could tell them whether whether the fetus is affected or not. Coming to the third case, this was a global developmental delay, of a 6-year-old child, but the lady was already in her 19 and a half weeks pregnancy. Of course, now today until 24 weeks, she's allowed to terminate, but with the high-end genetic testing, it takes a little, about 3 to 4 weeks for a report to come through, and hence she missed this testing over here. But when the anomaly scan was done, and the MRI scan, so the anomaly scan was normal, there was no sign of infection, but the MRI, showed mild HEI. Now this is something where counseling comes into place because this patient did not even know what obviously wouldn't know what HEI is all about. So that's why a kind of a counseling, this is what HEI is and how the child has suffered, or why the child has had a the mental or intellectual disability in the child. So in this case, we do provide a summary, mentioning that we have, done this kind of a counseling with the patient and the husband or whoever accompanied the patient. We advise chromosomal microarray in a child as a first trial testing, followed by clinical exome. So if we had a negative microarray report, and there was strong, dysmorphic features and a lot of things, which is why exome sequencing was suggested to them. So basically, this is the kind of, so here we have talked about microarray. The last case is RPL. Here the child had, esophageal atresia, and on a CMA, no abnormalities were detected. Here we asked them to do an exome testing, and we found a variant of uncertain significance over here. I'll just go to the next slide, which will say what is the VUS and why do we get stuck in such cases. So it is something like if it is a pathogenic, we are sure that this is a positive. If it's a benign variant, I know this is not causing a disorder. But when we get a VUS, this is a variant that we have found in your gene while testing it, but we are unsure whether this has caused the disorder. We did go back and ask the parents to test, and the parents were found to be carriers. So this is how we were able to tell the patients that, okay, maybe in your next pregnancy, they need to look for this variant. So as I mentioned, pathogenic and Pathogenic and benign usually make our lives easier, but when we land up with something like uncertain significance, we do face a little challenges over here. And these are the, during counseling, we just put across these kind of things that, half the time, 50% of the time, we do not know the reason of your, pregnancy loss. But then there are others which are, anatomical factors or the, the infections or the genetic predisposition. So I thank you for your kind attention.
Thank you, ma'am. I think we'll have comments on the questions at the end after Dr. Gandhi's talk. I request Gandhi sir to share his experience about inborn errors of metabolism.
So I'll be doing the last job. मैं लोरी गा रहा हूँ, आप सुना है. I thank my society for me being the last minute intruder in this program. Just when I saw the program, that I would be also passing some message which is of importance and is being neglected, and just to make us aware, sensitized to this issue. I'll be presenting you in about 20 minutes the experience which we had at my clinic about finding out the inborn errors of metabolism. So, inborn errors of metabolism is a large group of genetic diseases that result from a defect in an enzyme. We know that to run our body there are thousands of enzymes which are involved in different chemical processes, and those all enzymes, there something could go wrong and a defect can develop in an enzyme. The defect could be there in a transport protein, or there could be this can result in a block in a metabolic pathway. What would happen in the inborn error of metabolism? That is, what are the various pathophysiological ways? There could be toxic accumulation of substrate before the block. There could be intermediates from alternative metabolic pathway, or there could be defects in energy production and use caused by deficiency of products beyond the block. The incidence of inborn errors is quoted is around 1 in 800. It is in the international literature. But I believe that this is more in our country, particularly our area, where the incidence of consanguinity is quite high. Obviously, it varies with the race and ethnic groups. This usually presents in the neonatal period or infancy. The high index of suspicion is necessary for this condition. So we should be sensitized with this particular condition. And when we find that the infant which is with us after delivery, or a baby which goes home is presenting with certain symptoms, we'll come to that, then we should suspect the inborn error. There are about 1,000 inborn errors which can happen due to metabolism. Now, diagnosis, it comes under prenatal screening, prenatal diagnosis, and neonatal screening. this is actually a paper which was presented in July 2001 in the in the National Conference of Rare Diseases, and just presenting the same data. So it's till July 21, we had done about 138 prenatal diagnoses. This is only monogenic disorders. This does not include the microarrays and karyotypes and fish. All those are not included in this. The 138 are the cases which are the monogenic disorders. The common ones like the beta thalassemias, the SMAs, to the rarest of the rare ones like the Raine syndrome and those kind of things. This Raine syndrome case was published sometime back in an international journal. Out of this 138, we checked for inborn error. We had about 10 cases who had problem related to the inborn error of metabolism. These are the errors these are the cases which we came across during this period. The ornithine transcarboxylase deficiency, this is urea cycle disorder. Niemann-Pick disease, quite common. Propionic acidemia is also quite common. Homocystinuria due to MTHFR gene mutation. Sialic acid storage disorder. Methylmalonic aciduria. And the last case, we could not solve the puzzle, but the baby was born normally and is doing well. I'll just go through shortly to those cases, and there is some common trait which I'll discuss at the end of all the cases. This is a particular case, second degree consanguinity, cousin brother, Solapur. Index case was a FTND male, died at the age of 1 year. The baby had postductal coarctation. The diagnosis in the clinical material which was available of the first baby was a liver biopsy report which was suggestive of Niemann-Pick disease type B. No molecular workup was there in the index case. On this particular information, we did a prenatal diagnosis with the amniotic fluid fibroblast culture. We checked for the sphingomyelinase and the galactosidase activity that turned out to be normal. No. We have done the follow-up till now. This is till 25th August 21, but still this baby is doing well and is normal. This is the report. Now this is another case. There is no history of consanguinity. First was a LSCS, female, alive and well. Second is a Caesar, male, died at 2 years. In this case, fortunately, there was a confirmation by the molecular study that there was a SMPD1 gene mutation. We did the same study in the CBS. Unfortunately, we found out that this was an affected fetus. There was a compound heterozygous variant in the exon 2 of the SMPD gene. Termination was carried out in this pregnancy. This is the report. Then this is a case of Niemann-Pick disease. The index case died at the age of 21 months. The diagnosis, the material or the information which was available was liver and bone marrow biopsy, and on that it was suspected that it could be the Niemann-Pick disease. Taking that, we did the CBS and we did the sphingomyelinase and beta galactosidase activity, which was found to be normal. Baby was born normally and is doing well. This is the report. You can do the molecular study, or there are certain diseases where you can do the enzyme activity on the amniotic fluid and know whether the baby is affected or not. Now in this case, the wife is a beta thalassemia carrier, husband was normal, first stillbirth microcephaly, second birth asphyxia, died on second day. In the second pregnancy, fortunately there was a neonatal screening was done, tandem mass spectroscopy was suggestive of fatty acid oxidation disorder. Then on that trait or information, we proceeded with the CBS plus parents. We found out that the mother was heterozygous for propionic acidemia. Father was had a normal or wild type status. The fetus was a wild type. There was the fetus did not have a abnormal gene, and this baby turned out to be normal and is doing well. This is the report. Now, this is another case of propionic acidemia, second degree consanguinity, that is the maternal cousin brother, mouse womb. Index cases, all pregnant 4 females all have died on day 6. 4 babies have died on day 6. TMS and urine chromatography, tandem mass spectroscopy and urine chromatography was done in the third case, the third pregnancy, and that was suggestive of propionic acidemia. On this thread of information, we proceeded with the prenatal diagnosis. We did the CBS. Mother and father were found to be carriers for the propionic acidemia. Fetus was also a carrier for propionic acidemia, and after 4 pregnancies, this particular patient had a nice baby, and that baby is doing well. This is an interesting case. The infantile salic aciduria, it's a storage disorder. There was a second degree consanguinity, paternal cousin, Solapur. First was second trimester IUD. That was a male 600 gram. There was only a small USG report that was showing an image of pleural effusion. Baby had pleural effusion. Now in this pregnancy, the patient presented with hydrops fetalis around 20 weeks. There was fetal anemia, which was non-immune. So those were the pictures. There was ascites, there was pleural effusion, pericardial effusion. So all it's a hydrops fetalis. All the criteria they are fitting in the hydrops fetalis. And then we did the fetal blood sampling and did the exome study. It was found to be salic acid storage disorder. In the subsequent pregnancy, this particular pregnancy, this exome sequencing, this particular mutation is in the homozygous state. So this patient, that particular hydrotic pregnancy was terminated. After that, she conceived again. In this pregnancy, the fetus was normal and the baby is born and alive and well, doing well. So this is case of methylmalonic aciduria. The index case, first pregnancy died at day 5. Second pregnancy, LSCS, died at 2.5 months. Now here one point I wish to bring that many a times we say that the first delivery, if there is a neonatal death, if there is a stillbirth, in the second pregnancy, invariably a cesarean section done where there is no any real obstetric indication. We should restrain from such decisions because we are putting this mother in more trouble without knowing what had happened in the last pregnancy, and we are increasing her trouble and probably the chances of childbearing for the next pregnancy. So, unless we are justified in doing the C-section for this pregnancy, and not just on the indication that BOH, some stillbirth which is not exact cause is known, or neonatal death, where there is no defined cause as to something obstetric injury or that kind of thing. Now in this case, the second pregnancy, fortunately, screening was done. It was suggested of methylmalonic aciduria. Prenatal diagnosis was done in the next pregnancy. With this all workup was is before coming to me. With this information, we did the prenatal diagnosis on CBS and parents' blood. Fetus was heterozygous. Parents' carrier status was confirmed. And this fetus, this pregnancy, this particular patient is doing well. Urea cycle defect, ornithine transcarboxylase deficiency. This is 22 years lady, six pregnancies. First is a female alive and well. Second is a female alive and well. Male died at day 4, male died at day 4, pregnancies. Fifth, antenatal care and delivered with me. It was a male neonate, showed raised ammonia, jaundice in the neonatal period. the tandem mass spectroscopy and uric chromatography was normal. We did the exome and we found that the ornithine transcarboxylase deficiency is an X-linked recessive disease. This baby died at day 7, but then we could define the cause in this particular case, and we did the prenatal for the next pregnancy, and now the baby is doing well after the next pregnancy. Now, after this pregnancy, the testing was negative for this particular abnormality. That is again, that was a female child, and the baby is doing well. Homocystinuria, there was a second degree consanguinity, paternal cousin, Solapur. Wife was a beta thalassemia carrier, husband was normal. First pregnancy, second pregnancy, third pregnancy, spontaneous first trimester abortions. Fourth pregnancy, she was referred at 35-36 weeks for opinion. At USG, she had polyhydramnios and facial dysmorphism. The LSCS was done by the referring doctor. The baby died on day 35 undiagnosed. These are the ultrasound pictures which were this ultrasound was done with me. You could make out some facial dysmorphism, the protruding upper lip, the long philtrum, the bridge of nose, the mid-face hypoplasia. Those are the things which you could make out in this particular image. In the next pregnancy, this patient was with me right from the beginning. Antenatal care and LSCS both were done in this pregnancy. The NT was screen positive, but then the karyotype was normal. Newborn TMS and the uric chromatography was suggestive of homocystinuria and hyperhomocystinuria. Exome sequencing was done. It was the MTHFR exome 9 mutation was found. Does that confirm that homocystinuria due to MTHFR gene deficiency? The baby that time was just born. It was hospitalized about 30 or 40 days life. Junior radiology was looking after this baby. This baby is now almost 1.5 years old, has a lot of neurological problems, has some developmental delay, has some physical handicap, but then there are some treatment ways for this particular baby which have been babies being treated, but this baby doesn't have a normal quality of life. This last days I told you that there was a heterozygous citrullinemia was detected, but then we could not come to the conclusion in this particular case. Baby delivered and is doing well. They lost the follow-up now for this, but this baby was normal till 6 months and then died suddenly at 6 months. We don't know the cause. This case is lost for follow-up. No, we don't have a further follow-up this case. So to conclude, inborn error is not uncommon. It causes perinatal and infant mortality. Incidence for India could be higher than the incidence quoted in the literature due to the high prevalence of inbreeding. Undiagnosed inborn errors could be common cause of recurrent fetal and neonatal losses. As I said, high index of suspicion among the neonatologists, pediatricians, as well as the obstetricians is must. Prenatally, polyhydramnios, abnormal growth, facial dysmorphism are the signs, and when you find these things, you must keep in mind one of the things: inborn errors of metabolism. Now, in such situation, the best policy which I have adopted is to do a DNA extraction and keep the extracted DNA result from that. Whenever you find a polyhydramnios, anything abnormal, to take out the fluid, CBS, blood tissue, fetal blood, whatever material you have, or if you can't do it in pregnancy, do it immediately in the neonatal period and put the DNA. It doesn't cost you much. Then maybe that after some time, whatever has happened, patient is out of the grip and all those things, and they are in a mode of sensible thinking, logical thinking, then you can do counseling. At a time when they are in distress, when the baby is in the NICU with so many pressures, they are not in a mode of logical thinking, and they would behave sadly, they would not do anything, and they will get stuck up, and they will move from one obstetrician to the other, and then the next, and that way they would keep on losing the baby. I remember the 5th gravida, which was there in the civil hospital few days back, Hiranpur madam, and 5 cesarean sections, no baby has survived. That something should not happen. Just 4 days back we have seen this case. So this is the best way you do an extraction. It doesn't cost 1,000 or 2,000 rupees. Then keep it in with the laboratory. Laboratory counsel and find out what has gone wrong. Another advantage of this is a clinical course, natural history of the disease. You will be able to understand when the baby is in the NICU. On the day one, you won't be able to come to the conclusion this is the problem. But as the things evolve, you will come more closer to your diagnosis about clinical diagnosis, and this information will help genetic laboratory to conclude. Because what happens in the exam, the madam would tell us that you find 3 or 4 mutations, and then which mutation is clinically correlating with this particular condition becomes a dilemma. Am I right? I'll be presenting one such case in the next our 11 February conference. It's a very big dilemma. It's a very interesting case. So to conclude, DNS and urine chromatography, neonatal stigma. There's dilemmas with spectroscopy and urine chromatography. You should use this particular test more and more. Those which are growth restricted babies, especially those who don't have any obstetric reason. Say a baby born out of a placenta insufficiency, I can understand. But then if everything is normal and you are getting a small baby, if you are getting a dysmorphic baby, if you are getting a baby which has a excessive cry, is irritable, is a refusal to suck, or is a sluggish, you can't establish a proper lactation. So any deviation, those deviations, you must watch them and at least do a TMS and urine chromatography. Many times you will be able to suspect those things and can proceed on that time. Spread the awareness and disadvantage of consanguinity. Whenever possible, at least those consanguineously affected families, I clearly tell them that if you are affected, it's likely that if you marry consanguineously into a family, your babies also will be affected. And there comes the role of preventive genetics, where you can do those molecular studies in their siblings who are about to get married. Especially so if they are getting consanguineously married and find out those particular mutations and avoid the accidents in their future generations.
Audience.
Whether we should do neonatal screening each and every.
Wait a minute.
That is ideal.
Ideally, whether we should do it in each and every patient or in the patients who
That is
have
ideal,
history of.
but that is not even followed in US and UK.
So we should do it.
Most ideal.
Ideally.
But then you know the cost constraints and so many things.
Cost around 2,000 something.
It's all with
Yeah, for 5 days is the
5
same
to
cost.
6,000 rupees.
Yeah.
That's their total delivery budget. But at least in those high-risk babies, we must do it.
Any more questions? I have questions for Metropolis. So whenever, madam, we send these samples for karyotyping and your opinion, you said you also undertake a lot of counseling. So is the cost included in the test or it's a separate cost for counseling?
No, this is a free
No, this is already included in the test when we are basically doing it for microarray and chemotyping results. But of course, when we have to look for other recurrent pregnancy loss or they need to do some more genomic studies, then this is a payable one. But of course, with the microarray, it is included, definitely.
Since you said in your talk about the NIPT being the definitive test, or you don't need to do invasive, I disagree with your this thing that no guidelines, or still the NIPT is taken as a screening test. 99%, that means still there is 1% chance of error. And if you know that it is good 99% for trisomy 21, 97 to 98% for 18-13, and maybe as low as 92 to 94 for sex chromosome aneuploidies, if I am not wrong. And with such a sensitivity for different chromosomes, I think NIPT can't be a final test. We need to do with some invasive and conformity. That is, those are still the latest guidelines. The International Society, the Prenatal Diagnosis Society, all those, they recommend that the final test should be an invasive test for confirmation.
Right. So yes, I also agree because both of the tests are screening tests. But what comes to my mind when we look at the data that we get, not just, I'm not talking about Metropolis, I'm talking about the universal data.
Yeah.
And what we actually see with trisomy 21 particularly, I feel even with 18 and 13, but with the lower recurrence. But with trisomy 21, we've seen, and an end-to-end correlation has proved it, that you can. And actually, sir, in the developed countries, people have moved, they have stopped doing marker testing and doing this. I'm not saying so, this is what is there in the literature, or it is what is the fact. So basically, instead of doing two screening tests, it is best to do an NIPT followed by invasive. And as I said, that more than 90-95% didn't have to get into invasive. So probably with that perception, I feel that it's a good test. Just a thought.
Yes. No, I think the time has come to give up double markers. Triple already is out. Now the time has come to give up the double marker, quadruple marker. You decide your own strategy and go for, if good in an NT, so do an NIPT. That would be, I think, the better option.
Can have just one screening test, whichever. I mean, whether they choose to do a dual, or an NIPT, it could be just one screening test. This has come after a lot of evidences. So.
If you have a test of sensitivity with 99%, why you go for a test of 70%? That is the logic. Anyway, the patient pays 4,000-5,000 rupees, an extra few thousands, and then you are getting a 99%. That is a good thing medically for the referring person also and for the lab also. Even most of the countries now, Australia, what they do is they first do the NIPT. Once they get a normal report, then they would proceed with the NT scan. They do the NIPT and they do the NT scan. They do the NT scans, most of their NT scans are transvaginal NT scans. Every country has a different protocol, every country has a different guidelines depending on the resources. So, I think
Any more questions, any more comments? Thank you.
Request our chairperson, please felicitate our speakers, Dr. Banerjee ma'am. Dr. Gandhi sir. Dr. Sumit sir. I request Jamma ma'am to please felicitate our chairperson.
I know I'm standing between dinner and you,
but I won't take much of a time. This is the official vote of thanks that goes to all the faculties, Dr. Gandhi sir, Banerjee ma'am and Sumit, the chairperson, Davde sir and director madam. And last but not the least, thank you Metropolis for being our academic partners. I request all of you to please register for the SFM conference on the 11th and 12th of February. SOGS is very much a part of the same with the Radiology Association. We have sent the links on your WhatsApp numbers. Let's please register and make it a great
Say that once more.
Yes, sir, sure. Thank you. Join us for dinner.